Good morning, everybody, and welcome to this webinar hosted by the WHO European Region, the Office for Investment in Health and Development. It is fantastic to have you all here online today talking with us about this particular hot topic at the moment. This webinar brings together regional colleagues and researchers and practitioners to exchange experiences, emerging approaches on climate adaptation and health protection. We have a fantastic range of speakers for you today from across the region, focusing on how we keep people safe from the health effects of heat. So we're going to build upon the outcomes of the Flanders conference and how to implement health and wellbeing policies on climate change. So welcome everybody, it is great to see you. My name is Rebecca Masters. I'm a consultant in public health here in Public Health Wales in the United Kingdom, and I am joined today by a great bunch of panellists. I'm in charge of the moderation today. We have got a bunch of presentations for you. Please do pop your questions into the chat and I'll be delighted to read them out to the speakers after each presentation. And then we'll have a short break partway through the session. I'm now going to hand you over to my colleague, Kira Fortune, who's going to talk you through a bit more about what we're here to do today.
Thank you so much, Rebecca, for that very kind introduction, and also a warm welcome and good morning to you, colleagues, friends and partners. It is, of course, a great pleasure to welcome you to today's webinar on healthy climate resilient communities, heat pollution and health protection in regions and cities. And on behalf of the WHO and Regions for Health Network, I would also like to warmly thank all of our speakers, participants and partners for joining us from across the European region and beyond. Now, climate change, of course, is no longer a future threat. It's a present-day public health challenge. And across our region, we are witnessing more frequent and intense heat waves, deteriorating air quality, environmental degradation, and of course, growing pressure on health and care systems. These impacts are not felt equally. They disproportionately affect older persons, children, but also people living with chronic conditions, and of course also those facing social and economic vulnerabilities. At the same time, we are seeing extraordinary leadership emerge from regions and cities. Local and regional authorities are often the first to respond when temperatures they rise and when communities they face environmental hazards and when health services come under strains. So regions and cities are very much uniquely positioned to shape healthy environment through planning, housing, transport and social care and public health policies. Now, over the past several years through our work with the regions and cities across Europe, we've learned an important lesson, and that is, of course, that climate adaptation cannot be pursued in isolation. To be successful and sustainable, it has to be connected to the broader well-being objectives. Nature-based solutions, urban greening, cooling strategies, and healthy urban planning can simultaneously strengthen climate resilience, improve mental well-being, foster social cohesion, and create more livable communities. These are not competing agendas, rather they are mutually reinforcing investments in healthier futures. As WHO, we believe in supporting a process that must ultimately be owned and led by regions and cities themselves. Local and regional authorities understand the reality of their communities and are best placed to translate broad policy ambitions into practical action. And in preparing today's program, our speakers have collectively chosen to focus on concrete experiences and implementation challenges, from heat protection in hospitals, nursing homes and outpatient care settings to healthier public spaces, indoor environments, as well as approaches to reducing environmental risk. And this practical focus really reflects the growing demand for solutions that can be adapted and applied in real-world settings, so to speak. Today's webinar will build upon the important discussions held in the Flanders conference on implementing health and wellbeing policies on climate change, and it provides a unique opportunity to really move from ambition to implementation by sharing practical experience, evidence, as well as solutions. As you will have seen, the agenda highlights several critical dimensions of climate resilience and health protection, strengthening heat preparedness in hospital, and long-term care settings, protecting health in outpatients and community-based services, creating healthier indoor environments, advancing innovation cooling solution, and ensuring that health considerations are integrated into broader decisions affecting our communities. Now, what is particularly encouraging is that many of these solutions deliver multiple benefits. Measures that protect people from extreme heat can also improve well-being, reduce inequality, strengthen social cohesion, and contribute to more sustainable and livable communities. Peer learning, of course, is particularly valuable in this context. Many regions face similar challenges, yet operate within very different governance structures, climates, and resource environments. Networks such as the WHO Regions for Health Network and the Healthy Cities Network provide unique opportunities to really exchange experiences and learn from both successes and setbacks, but also to accelerate implementation through collaboration rather than duplicating efforts. One such opportunity is the forthcoming WHO Climate Change Commission that will be presenting its recommendations at the Cork Mayor Summit that will take place from the 5th and the 6th of October this year. I will speak more about that when we close the webinar, but also just to say that this really represents a very important step in supporting climate action in cities and in regions, as well as the role of local leadership in addressing the health impacts of climate change. And we, of course, look forward to continuing the conversation on this summit. As WHO, we strongly believe that health must be positioned at the center of climate adaptations and resilience planning. Health is not simply an outcome of climate action. It's one of the most compelling reasons to act. And by framing climate policy through the lens of health and well-being, we can build a much stronger public support, foster cross-sectoral collaboration, and accelerate implementation. But before we begin, I would, of course, also like to express my sincere appreciation to the WHO European Centre for Environment, Climate Change and Health, based in Bonn, and in particular, Vladimir Kindrovsky for his and his colleagues' contributions to today's webinar. As you know, WHO Europe will soon launch its new guidance on heat health action plans coordinated by the Bonn office. And whilst this guidance has not yet been published, we are very pleased that colleagues will be able to share some reflections and emerging considerations on this increasingly important area of work. The challenge that we face is significant, but so too is our collective capacity to respond. And today's discussion reflects the strength of our networks and partnerships and the value of bringing together expertise from different sectors and disciplines. So I encourage, of course, all of you to engage actively, to share your experiences, and to use this opportunity to learn from one another. The solutions that we need already exist in many places. So our ask, of course, is to scale those, adapt them, and to ensure that no community is left behind. So thank you once again, colleagues, for actively putting this webinar together and for joining us for a very inspiring discussion. Over to you, Rebecca.
Thank you, Kira, for a fantastic launch into what we're going to go through today. You raise important points about the challenge we have in our cities and regions in relation to heat health. So I think we've got a fantastic bunch of colleagues on the call today who can talk us through. And on that point, I'm delighted to introduce to you all Petra Marinko, who is going to talk to us about health as a topic to help shift decisions. So over to you, Petra.
Good morning, everybody. I hope you can see my screen. Can you see my screen?
Yeah, we can see it. Thanks, Petra. But you're on me as far as I can see, so I don't think it's quite launched yet.
Can you see the presentation?
Yeah, that looks good.
Yes, thank you very much. Thank you. Good morning, everybody. It's great to be here, an honor to be here. And my name is Petra Marinko. I'm an architect and founder of Non-Tox Unicum platform and Non-Tox Hub Institute. And I work at the intersection of architecture, health, real projects, and implementation. I also serve as a new European Bauhaus advisor and integrate the values of beauty, sustainability, and inclusion in every step. And today I want to talk about something we rarely talk about in public projects and design projects. And this is what spaces are made of and how decisions about spaces influence health and well-being. Through my work, I increasingly realized that health is often missing from the project conversations, even though many decisions made during design directly influence well-being. So I would start with a very simple observation: how we design space. We think about light, we think about proportions, movement, but materials often come later at the end of the stage of designing and almost as a technical decision. And that's where the disconnect happens, because materials are not neutral and they shape the experience in ways that we don't immediately see. And in our work, we focus exactly on that layer, not as a theory, but as something that needs to work in real projects. And today I will show you where the gap is and how we can start closing it. And this becomes especially important in schools, libraries, healthcare environments, and other public spaces where many people spend time every day. In most projects, the sequence is predictable: concept, layout, budget, and then materials. At that point, choices are limited, and materials become something we adapt instead of something we design with. And this is not about individuals, it's about the system. By the time health enters the discussion, many decisions are already difficult to change. So, what do we optimize for? Cost, availability, aesthetics, compliance, rarely health. And yet public spaces are used by children, older adults, other vulnerable populations every day. And important, none of them answer one key question: what does this material actually do in space over time? What impact it has on humans using that space? Many questions we almost never ask. What material releases? How does it behave after years of use? What happens when multiple materials interact in one space? And perhaps the most important question: who is most exposed? Today, we are discussing climate adaptation, heat, air quality, pollution, and resilience. We speak a lot about sustainability, about energy consumption, water saving, food, mobility, but there is one dimension that is almost completely missing: the health of space and products itself. What we breathe, what we sleep in, what touches our skin, materials, textiles, floorings, walls, cleaning systems. They are part of every space, but they are rarely understood as a system, and they are rarely looked over from aspect of health, and the impact that they have is really huge. PVS flooring, PVC flooring, vinyl floors release plasticizers over time. The substances can disrupt the endocrine system and affect hormonal balance. MDF boards often contain formaldehyde-based resins. Formaldehyde is known irritant and carcinogen, linked to respiratory issues and long-term health risks. Foams, even when
Hi Petra, sorry to interrupt you. I don't know if others are hearing it, but there's a slight problem with your sound. I don't know if you wanted to just test the sound
short-term
again to see if we can restart. Oh, Petra, I think there might be a challenge with your
headaches.
connection. Oh, sorry for that interruption there, folks. I'm hopeful that Petra will join us shortly and we can continue. We'll just give her a moment to see if she can get back online for us. Here she is. Hi, Petra. Can you hear us okay? Sorry, folks. Just bear with us a sec whilst we try and figure out the technical challenge that we're just having with Petra.
Can we hear me?
Oh, you're back. Yes. Fantastic. Yes.
Oh, I'm not sure where you lost me.
You had been talking about mobile phones, I think, and you'd got past vinyl floorings in terms of the challenge
Okay.
of, and so we were just up to that bit. I don't know if you were able to skip back to there at all.
Okay. Can you see my presentation?
Yes, thank you.
Okay, thank you very much. So I will go back on this slide. We already have the knowledge. There are databases, there are guidelines, there is extensive research, but it doesn't easily reach the point of decision, and it stays fragmented, too complex to navigate, too technical to apply, too far from real projects. And as a result, it rarely becomes part of everyday practice. The challenge is not knowledge, the challenge is implementation. There is a gap, and we try to come into this gap. So our work is very simple. We translate, educate, apply, test. Take knowledge about this and bring it to real projects. We work with what already exists and move it. Speak about this and putting health at the table. We do the talks, open, inclusive, without a stage, where we open the conversation, not abstract, but grounded for all. We organize educational events, conferences, non-talks days, where it becomes tangible. People don't just hear about it, they experience it, touch, compare, and understand. We created a non-talks pop-up library of curated healthier materials, so the visitors can see, smell, touch, and compare materials, transforming complex scientific knowledge into tactile learning experience. And then we implement in real spaces with real constraints, budget, standards, and use. And it's not about removing materials, it's about choosing differently. Mineral paints instead of synthetic ones, solid wood instead of composite boards, linoleum instead of PVC or vinyl floors, solid wood, clay and lime finishes instead of sealed systems. And these materials are not new. We simply stopped using them. We test all this in our projects. And today I would like to expose one really special. A public interior developed next to a library. We call it Healthy Public Living Room. A place designed for connection, well-being, and community life. We asked a simple question. What happens when health becomes one of the design criteria? Not only function, not only budget, not only aesthetics, but health. Not there was no ideal conditions. There were real constraints. It was a municipal project. Public procurement defined materials. We used reused furniture. We did it low budget in defined time, and we proved it can be done, and healthier is possible. What is different is not only measurable. Air feels lighter, people stay longer, the space feels calmer. And for people experiencing loneliness or social isolation, these small differences really matter. And this is important because perception is part of performance. And the level that this can scale is municipal. Changing governmental systems takes time, sometimes decades. And in between, people breathe, live, feel. Municipalities work for and with citizens, and they have powers for bigger changes, for schools, for libraries, public housing, one decision affects hundreds, sometimes thousands of people. And this is where it becomes systemic. So when we start looking at this layer, what spaces are actually made of, what they release, how they affect us over time, we realize something. And this is not only a technical question, it's not only about materials, it's how we design, how we decide, and how we connect knowledge and practice. And this is exactly where broader frameworks come in. The new European Bauhaus is one of them, not as a concept, but as a way of working. It brings together sustainability, inclusion, and aesthetics, and importantly, it asks for transdisciplinary approach, a way of connecting fields that have no longer been separated. And this is where the material layer becomes critical, because it sits right in between environmental impact and human experience, between design decision and health outcomes. If we don't address it, the connection remains incomplete. If we do, these dimensions can finally start to work together, and health is often the missing layer connecting sustainability, inclusion, and beauty. It's about changing the baseline, from isolated decisions to something expected, from pilot projects to how we build, from awareness to requirements. And this is to conclude with something practical. First, we start asking questions. Second, we choose fewer and simpler materials. Complexity often increases chemical load. Third, think in systems, not products. Every layer matters. Read labels, learn to read product specifications, bring health into procurement discussions, bring health into design conversations, and finally, start somewhere. Our project is enough to begin. And one project is enough to begin. Change does not require perfection, it requires awareness and consistency. And once you start seeing materials differently, it becomes impossible to ignore that impact. Once you know, you cannot unknow. If there is one thing to take from this, is that materials define health. We don't usually think about it like that. We think about medicine, we think about lifestyle, but health is also shaped by the environments we create every day. And materials are a big part of that. What we choose, what we allow into space, because nothing stays without impact. Everything leaves a trace in the space and in us, and choices leave traces. If we look how we build today, we already have knowledge. We know more than before. The knowledge and the challenge is not information. The challenge is application of all this knowledge. Because design is not only about ideas, it's about consequences. And healthier communities begin long before healthcare in a design phase. Health should be at the table from the beginning. So let's build with that in mind. Thank you very much. I hope you get to see the most of the presentation, and I hope you get the message that I wanted to share. Thank you.
Did. Thank you so much, Petra. That was genuinely really interesting. And what I love most about when we are brought together in such a manner is just the ability to learn something that we didn't know before. So there's a quite significant amount of takeaways from your presentation that I particularly enjoyed. And I can see how it relates to some work we're doing also at the moment around our medical devices and how we looking at, how are medical devices, what goes into them, where are they manufactured, what are the processes that go into them, and how can we either decarbonize them or make them as sustainable or from that circular economy perspective as much as possible. So that what you're talking to, I think, speaks to a lot around not just how we adapt our building space, but anything that we procure, that we purchase and buy. So thank you very much. I really enjoyed your presentation, and you answered one of the questions I had already. But secondly, a quick question, if I may. Do you think it's possible to create healthier environments without significantly increasing the cost of them?
This is the question that I get the most often, and my answer is usually yes. not always, but often, because many healthier decisions are not necessarily more expensive. Sometimes they simply require different questions that are addressed earlier. So in my experience, time is often more important than budget. So we had this healthy public living room project, which was not more expensive, which didn't take longer time, but we just asked the right questions in the early stages. So we changed the vinyl floors from linoleum, and we changed the impact of health on people with one simple decision. And I believe that if we reduce 1% of toxicity that we can with materials, we have reduced 1% of impact on our health. And that is a lot. So if we add, and each percent adds a percentage, I think that's a wonderful thing that we can do. And when health enters the discussion at the beginning, I think most options are available, but it's just the knowledge that we think that it's missing from architects, from designers, from people dealing with real projects, the awareness of municipalities and other people dealing with public procurement is still on the table when and a big problem. So I would say yes.
Fantastic. Thank you so much, Petra. Colleagues listening, I hope you're enjoying the presentations, and please do pop your questions into the Q&A chat, because we will have an opportunity to ask some more questions later on. But for now, thank you very much, Petra, for your contribution this morning. I've really enjoyed it. I'm now going to pass colleagues over to my esteemed colleague, Vladimir Kendrovsky from the WHO Bonn office, who is going to talk to us about the heat health adaptation plan. So Vladimir, over to you.
Thanks, Rebecca. Good morning, everyone, and I'm very pleased to give you a short advanced presentation on the second edition of the WHO Heat Health Action Plan guidance. So, of course, as mentioned before by Kira, the guidance will be officially published on 11th of June. So today is something as a premiere, in fact, an opportunity to introduce the main structure, messages, and practical tools before the formal launch. So my focus today will be on how the guidance helps countries to move from recognizing heat as a health risk to organize practical, coordinated, and sustainable action. May I have my presentation, please? Next slide. Yes, next slide, please. Great. So we'll start with why heat health action planning matter. Of course, also we hear from Kira that the extreme heat is no longer an occasional emergency. So the world is warming at a faster rate than any point in the recorded history. So each decade in the latest 50 years is hotter than the previous one, and more than half of the observed increase in global average temperature was caused by climate change. And the heat-related mortality has increasing for more than 60% in the last decade compared with the 90s, with the average about more than 500,000 registered deaths, heat-related deaths. So, and unfortunately, there's no good news for the future. Under the 2-degree scenario, this number will increase for 3 times by 2050. So that's why the heat health action plans matters, because they provide the planning architecture to prevent avoidable deaths, to protect people at increased risk, to enable early action, to reduce pressure on the health system, and coordinate sectors before heat becomes a crisis. So proactive planning is safer, cheaper, and more effective than reactive response. Next slide, please. Of course, our new guidance built on the nearly 2 decades of work in WHO European region. The trigger was 2023 mega heat wave facing Europe, and then since our publication, the first guidance in 2008, the heat health prevention became more systematic. And the updated guidance reflects the new evidence, implementation experience, and the growing need for regions and cities to act earlier, better, and more consistently. Next slide, please. The aim of the guidance is to support countries to develop, strengthen, or implement the heat health action plans at national, regional, and local levels. The overall goal is to protect health from extreme heat through coordinated prevention, preparedness, response, and learning. And you can see the objectives are to reduce the heat-related health risks and to support consistent implementation across sectors and governance level. Next slide, please. I'm very pleased to share, to promote our new WHO Heat Health Action Plan framework, because this slide shows the full structure of the guidance. Part one is the core Heat Health Action Plan framework, but built around new 8 core elements. The part two translates the framework into user action briefs for priority sectors. And part three provides a public health message bank. So the guidance is not only a conceptual framework, it's also an implementation package. Next slide, please. The core element one, governance, is the starting point, and heat health action plans needs a clear lead bodies, a coordination mechanism, and a greater roles and responsibilities. Without governance, heat action remains fragmented. So the important point here is that governance must fit the country context, national, regional, or local, but it must clearly answer who leads, who coordinates, who funds, and who is accountable. Next slide, please. The second core element is heat health warning system, because the heat warning system is not just a weather alert. It must be connected to the heat health action plan, governance, communication, and response arrangement, because the effective systems use locally appropriate threshold graded warnings and clear decision pathways. So the warnings is only useful is if it's trigger timely and proportional action by health services, of course, local authorities or care providers and the public. Next slide. This element about the population that's increased risk ensures that the heat health action plans is equitable. So risk is not distributed equally. Some people are more physiologically sensitive, some are more exposed, and some have lower capacity to protect themselves. So the heat health action plans need to identify and map these groups and then link that mapping to the target outreach, communication, health and social care action. Next slide. Communication is not just sending also messages during the heat wave. It is a strategy to build heat literacy before, during, and after hot weather. So messages needs to be timely, trusted, but also tailored and actionable. A good communication strategy also works through partners, health professionals, local authorities, schools, employees, social care, community leaders, and the media. Next slide. It's the core element 5 about the health system resilience, because we know that extreme heat affects all health system functions at the same time. So it's increased demand while also putting pressure on staff, facilities, infrastructure, technologies, and supply chain. So the health system resilience means maintaining safe and effective care during heat events. It's not only emergency response, it needs to be embedded in the routine service planning, primary care, workforce protection, and business continuity. Next slide, please. Core element 6, reducing heat exposure, is connected with our previous presentation. because this element is about the reducing the actual heat load people experience. It includes immediate measures such as shade, hydration, cooling spaces, and behavioral advice, but also long-term measures such as building design, retrofitting green and blue infrastructure, shading and heat-conscious urban planning. Reducing exposure can be life-saving, especially for people at increased risk. Next slide, please. It's about the core element 7, heat health surveillance, because it's allowed to move from assumption to evidence-based action. The surveillance should integrate meteorological environment and health data, of course, including near real-time information on mortality, morbidity, syndromic indicators, and health service use, because by this it can detect health impacts early, can adjust response measures, and link surveillance back to the warning system and heat health action plan activation. And the last one is the core element 8, monitoring, evaluation, and learning. This is the improvement engine of the heat health action plan, because monitoring tells us whether plan action will implement. Evaluation tells us whether they work for whom and with what gaps. And learning ensures that the findings are used before the next heat season. This element is essential because heat risk population, climate condition, and institutional capacities are changed over time. So we need to have this in place. Next slide, please. Now we move to the part 2, and I will try to be under the great timing of my presentation. The user action brief, translate the heat health action plan framework into action. So we are here to make our guidance more practical, because the user action briefs translate the heat health action plan framework into role-specific tasks for different sectors. They help each audience understand what they need to do before the hot season, during the season, during extreme heat event, and after the season. This is very important, because heat health action plan implementation cannot sit only with the health sector. Next slide, please. For the health domain, the key actors are the health authorities, public health practitioners, facility manager, and frontline health workers. Their role is to lead or support heat health action plan development, to coordinate outreach and surveillance, prepare health facilities and staff, and ensure that heat-related illness is recognized, treated, referred, and reported. Health system need to prepare before the heat even starts. Next slide, please. This is how it's looked for each of these key actors, what they need to do before the season, during the extreme heat, during the hot season, and after. And it's applied for all user action briefs later on. Next slide, please. Occupational domain. Heat, of course, heat is a workplace hazard. So authorities, inspectors, and employees need to assess exposure, to define the threshold, to adapt work rest cycles, to provide shade and water. Then workers and first responders evaluate what happened after each heat season. This is especially important for outdoor workers and workers in poorly cooled indoor environment. So, as I mentioned, the table for what to do, when, and how is for each of these key actors. Next slide, please. It's about the urban and built environment domain, because this is central to prevention. Local authorities and city managers can reduce the heat exposure through urban policy investment, cool public spaces, shade, water access, green and blue infrastructure, transport planning, and emergency coordination. And this is where short-term heat response connected with long-term climate adaptation. Next slide, please. Just to add that for all of this, we have case studies. So globally, this is this guidance is published in our region, but it has a global relevance. The social care domain is critical because many people at the highest risk depend on care services. Of course, care homes and home care settings can become high-risk environment if heat is not actively managed, and we also have the provision of action for the key actors in this domain. Next slide, please. Education and childcare domain. Of course, educational authorities and facilities heads should ensure that heat plans are in place, outdoor activities and schedules are adapted, classrooms and cooled where possible, and staff can recognize the heat illness sign. Same for this group of actors, the actioner provide what they have to do, when and how. Next slide, please. Now we move to the last part. It supports public health message bank, which support the communication element on the heat health action plan. The message bank helps turn alert into clear advice, what to do, who is at risk, and where to seek help. This is useful because in a heat event, there is no time to start drafting messages from zero. So we prepare this as ready to take message because they can improve the consistency, speed, and trust. Next slide, please. And here is the how we do for content ready for use for the different settings presented here, and all of this can be adapted to the channel such as social media, radio, TV, and so on. And next slide, please. I would just like to share with you yesterday we publish our news and we launch our Keep Cool campaign, where you can find a lot of messages, videos, and promotion materials how to stay cool during the heat. And the last slide, please. It's how the three parts work together. So this final slide is, let's say, take home message. As I mentioned, the part one provides the framework. The part two turns the framework into sector-specific action. And part three turns heat warnings into practical public advice. Together, they help countries to move from fragmented response to coordinated prevention, preparedness, response, and learning. That is the real value of this updated heat health action plan guidance. Thank you.
Thank you, Vladimir. That was a really interesting run through of quite complex guidance that I know has been in development for a number of years. So I'm really grateful for that early view of what looks like something that would be actually incredibly useful. And what struck me was the bank of public health messaging, because messaging is expensive to develop and to do it well. And actually, where you have public health agencies that are able to draw on an internationally renowned organization that has done that work for us, it saves, not only is it more impactful, but it saves us a huge amount of cost as public servants as well. So I particularly look forward to having a look at your public health messaging when that comes through. And the focus that you made around social care environments is something that I know that we're all really challenged with at the moment in terms of how we ensure the most vulnerable people are kept safe during these heat health challenges that we have. So thank you, Vladimir. I really enjoyed that. I'm not going to pause for questions there because I'm going to go straight over to Anya, who's my colleague Anya Gopfert from the UK Health Security Agency, who's going to talk to us about heat health within the hospital settings environment. So following Anya's presentation, we will have an opportunity for some questions to Vladimir and Anya. So please do pop them into the Q&A section. But now if I can invite Anya to come forward, and we will go through with that one.
Hello, good morning, everyone. Can you hear me okay?
Yeah, we can hear you great. Nice to see you, Anya.
Good to see you. Can I just check if it's possible to share the slides? Perfect. Thank you very much. So, my name's Anya Gopfer. I'm a consultant in public health, and I work at the UK Health Security Agency's Climate Change and Health Centre. I'm going to talk to you about a piece of work that is ongoing and recently started around building heat resilient hospitals, explain to you what we are planning to do and where we are up to, and then hopefully also ask for any kind of case studies or experience that you might have in this field that we can consider within our work as well. Next slide, please. Next slide, please. So I suspect that many people here on the call today are already fully aware of why this is an important area, but just to emphasize some of our recent kind of summary of the evidence. We know that particularly in England and in the UK, although I suspect this is a problem in the rest of Europe as well, that a huge amount of hospital buildings are very vulnerable to overheating. So we found in our research that 90% of hospital buildings are vulnerable to overheating. And whilst this is obviously related to the outdoor temperatures, sometimes the indoor temperatures within hospitals can also be very high, even if it isn't particularly warm outside. We also know that, for example, indoor temperatures can exceed 30 degrees, even when the outdoor temperatures are cooler. And whilst we don't have any specific limits that are recommended in terms of indoor temperatures, we know that temperatures that are higher, and particularly those above 26 degrees, are associated with health impacts for patients. And one of the really important things around this area of work is that people in hospital are, of course, more vulnerable than the general population to the impacts of these higher temperatures. They're in hospital for a reason. They're more likely to have another health condition or kind of be taking medication, which might make them more vulnerable to the impacts of heat. And therefore, we've got a particularly vulnerable population within a setting where they are unable to control the temperature or in the environment themselves, wouldn't be able to kind of go outside or kind of move themselves within the hospital necessarily to a cooler area. And so are very dependent on caregivers and policies and the structures in which they're based to be able to have an environment that is safe and healthy. Our current kind of research and estimate suggests that 1/3 of heat-related deaths occur in hospitals. So we know that we see peaks of mortality when there are periods of heat. And those periods of heat are not just extreme heat. Actually, differences from cooler temperatures to hotter temperatures, even not at extreme levels, can have quite substantial impacts on mortality. And actually, in our data at UKHSA, we actually see the biggest impacts on mortality in those periods of kind of moderate heat rather than extreme heat necessarily. And of these deaths that occur during heat, we think that about 1/3 of these occur in hospitals. So for all of these reasons, we think it's really important to deep dive into this area, build the evidence base for understanding what is the impact of heat in hospitals on people and what can we do about it. So I'm going to tell you a little bit about our plans. Next slide, please. In the UK Health Security Agency, we do what we call thematic assessment reports of the evidence base between climate change and health. This started in 2023, where we published the health effects of climate change in the UK, which is a kind of comprehensive summary of the impacts of climate change upon health. And rather than repeat this on a regular basis, we've decided to do thematic assessment reports, deep diving into specific areas where the evidence base wasn't quite clear or we needed further information. And the first one of those was published in November last year, and that was on climate change and mental health. And the next report, which is the one I'm talking about today, is around heat resilient hospitals. And then our future reports are going to focus on building healthy homes and healthy landscapes, as well as some scenario modeling on the future health impacts in terms of quantitative data and cost by 2050. Next slide, please. So what are we doing for the Heat Resilient Hospitals report? So we have undertaken a number of scoping workshops and research prioritizations so far, and I'll talk you through that in a minute. And because the evidence base in this area is kind of not necessarily comprehensive, we think that there will be, and there is, a lot of evidence that people will have from their anecdotal experience of working in hospitals, or maybe pilot interventions that they've implemented in hospitals, but not necessarily published. So we are holding a series of workshops with academics and with staff working in the healthcare system, to understand what they have experienced in periods of heat, and any pilot measures they might have undertaken to try to improve the situation. And we will be combining the literature review that we are doing with the workshop outputs to essentially draw together expert consensus on what we think the kind of implications of this are. Next slide, please. So after all of our scoping and initial kind of evidence review, these are the questions that we are aiming to answer. So we want to fully understand what the impact is of heat in hospitals on the people within those hospitals. So that includes patient groups, as I've outlined, but also obviously includes the staff as well who are working within the hospital, and what the impact of heat is on their ability to deliver patient care. We want to better understand what mechanisms actually affect people during heat. So is it physiological stress? Is it actually it's very hot overnight and therefore you don't sleep very well, and that has knock-on impacts on your health? And how does staff performance affected by heat actually have an impact on patient care? And we want to look at this also thinking about what's the different type of heat events. So I mentioned there's kind of moderate heat events where we have higher temperatures but not extreme heat. We have extreme heat, and we have scenarios where we have warm hospitals, but actually it's not too hot outside. So we want to also understand a little bit about the difference in these situations as well. We particularly think it's important as well to understand, as a result of the first question, what are then the impacts of economic costs of overheating in hospitals in terms of disruption to staff ability to deliver care, affected patient care. If we've got sicker patients, what is the economic impact of that? And are there preventative interventions, I'll come to this in a second, that we can introduce to actually minimise and reduce these impacts and costs? And then, as I mentioned, we're interested in understanding what the future looks like. So at the moment, we do not have, and I would be very grateful to hear from others if you have good data on this, but we do not have good data for the UK and for England about what the future impact is on hospitals that we expect to see as a result of heat. So what do we expect to see in terms of mortality? We've got some figures for that, but in terms of the impacts on people's health that results in them coming into hospital during a heat event, we don't have good modelling data on that at the moment. So we want to understand what the future hospital emissions in a 2-degree scenario in 2050 might result in. Next slide, please. So the second section is, in essence, what can we do about this? And we have started to look at the evidence base around cooling interventions in hospitals. And as I'm sure that many of you here can imagine, there is, in summary so far, evidence to suggest that air conditioning cools hospitals, and that's good. Now, that we could have all probably predicted. However, there are a couple of other things to bear in mind. One, we want to understand what the trade-offs are of air conditioning. So there's some concern around the impact of air conditioning on infection control. And I don't know if that is kind of fully understood in the kind of Northern European context. And additionally, there's obviously a trade-off for air conditioning in terms of the costs of retrofitting air conditioning or installing air conditioning into hospital stock where that's not currently the case. And additionally, there is the consideration of the energy demand to run air conditioning units in large buildings and large infrastructure such as hospitals. We also are looking at the evidence and trying to understand what interventions can we introduce that are not air conditioning. So what passive cooling interventions can be introduced, what behavioural interventions can be introduced to protect patients, to protect staff, and to reduce the impacts of overheating in hospitals. Our literature review and our workshops are considering anything in this space. So we don't need things to have a high quality evidence base to be considered. And we would like to understand, how feasible is it to implement these things? What are the consideration of potential risks, and what are the economic benefits and costs? And then we will be taking all of the answers to these questions and the work that we've done and summarising these into considerations for the UK government, for English hospitals, and working closely with our partners in Wales, Scotland and Northern Ireland to understand what this might mean for them as well. And then we will also summarise what critical gaps in evidence remain as a result of all of this work. Next slide, please. So just to summarise what will be in scope, so we're thinking about high indoor temperatures regardless of the temperature outside. We are focused on hospitals and secondary care settings, and we are looking at the impact of this on patients and disruption to service delivery as well. We would be interested in any evidence from any setting worldwide, particularly from anybody in a setting similar to kind of England that would be easily kind of transferable to our context. And we will be sharing the results in a published report in 2027. We are only looking at heat, and we're not looking at primary care settings or care homes in this report itself. Next slide, please. So where are we up to? We've already held our first workshop with academics, and we've got our second workshop with staff working in the healthcare system coming up shortly. And the literature review, as I've kind of highlighted, is underway. We will be sharing our initial evidence review findings internally in the autumn, and we will be aiming to publish this in 2027. So next slide, please. The final thing that I want to say is we would be extremely interested in any context, any evidence that you are aware of from your area of work, whether it's published or not, how well it's been trialled. We're particularly interested to understand evidence that's not been published. And if you are have got anything that you are aware of, we would love to hear from you. And thank you very much for listening. So I'll hand back to Rebecca.
Yeah, that was a really interesting presentation. And I think there's a huge amount for us to learn there in terms of the challenges of how we ensure. You touched a bit on the health morbidity and the health burden of heat towards the health and social care sector. And I think that's a great challenge for us working in this sector, is that the heat mortality challenges are often better understood because they're easier to count, unfortunately, than the heat morbidity. Now, the heat morbidity has a significant burden, not just on health, but social care more broadly. So thank you for your presentation. I think there's a huge amount in there that's beneficial to the wider system. We've got time for a few questions. So I wanted to bring Vladimir back online. I hope he is still there, because I think your two presentations together in terms of heat and their consequences, both for health and social care, are really key for us working in this space. So this is an opportunity for colleagues on the call to pop their questions in the chat. But whilst we wait for some questions to come through, I have one of my own, if I may. So Anya, you touched a bit on this in your presentation, but given the importance of heat adaptation within the health and social care setting, how do we manage that in the context of minimising our own our energy usage and our general work towards carbon mitigation measures in general, really? So we can't air condition our way out of this, can we? So what else can we do, and how do we manage that?
Sorry, you cut out for a second for me at the very end of that sentence. Could you just repeat the latter half?
Sorry. Yeah, sorry. The second part was, how do we manage our adaptation measures, I guess, within the context of how do we manage to adapt to heat within the health and social care setting whilst also keeping our carbon footprint low?
I think that is the question that's incredibly important for us all to be considering at this moment in time. And I would say there's always been a bit of a threat to a trade-off to our very limited resources in terms of, are we prioritising adaptation or mitigation at any particular moment in time? And I think in the report that I just kind of outlined, obviously air conditioning is the crux of that issue, in the sense of a kind of very clear and direct trade-off between adaptation in a particular moment versus the potential impact in terms of mitigation and reducing carbon footprint for the future, which is why we're so interested in understanding what passive cooling interventions and behavioural actions are available and do work and can be promoted to minimise any kind of long-term trade-off versus kind of the need to immediately provide safe environments for people's patient care.
Yeah, that makes a lot of sense. And it is the million-dollar question, isn't it, in all of this? So thank you for answering it. It felt like a bit mean question whilst I was saying it, but I was trying. It really struck me as we were going through the presentations following on from Petra's about how we manage that built environment and how we and the costs associated with that kind of architectural build and how we keep people safe. And I know when we were in Flanders, we had that discussion around some very significant adaptation measures that were put into the built environment around green and blue spaces, and just the quality of adaptation measures that are out there that we perhaps don't conceive of, and opportunities like this bring them together. Vladimir, I wonder whether you had any thoughts on this, because you mentioned it within your Heat Health Action Plan around some of the importance of green and blue spaces. So I wondered if you could draw a bit more on that perhaps for us in terms of how do we utilise green and blue spaces within the built environment for heat health?
Yes, thanks for this question. And I see this guidance in that regard as added value to many of the questions arise from the people, because reducing heat exposure is key. And then the various measures and activities, how we can manage this action and various levels. So we introduced if you remember the figure we proposed, we have already solutions on reducing heat environment at individual level, but also on dwellings. And when it comes to the city level, it's probably something interesting. A lot, of course, the green and blue space are the way of or increasing the shading and many other things are something which are implementing all around the Europe and the world, definitely. But it should be, and this is the probably the key, it should be systematic. It should be agreed with many actors, and we should work hand in hand, the architects, the urban planners, to work with the health departments and with the municipalities and the regions, just to have the proper, let's say, long-term perspective, what to expect due to climate change. And this should be a trigger in this action, because it can help all of us to find the denominator of climate change and put health in the leading role, and with this to find, of course, when it comes to blue and green spaces, there are many questions that needs to be response in advance about the pros and cons for many other areas, but definitely this is the way how we should act. And this heat health action plan can, under the government's governance umbrella, can support these actors to work together. Over.
No, that sounds fantastic. Thank you. Is it you say?
Sorry, I could not hear you.
Sorry, can you hear me now okay?
Yes, I
Yeah,
can.
fabulous. Sorry, you mentioned the date when the Heat Health Action Plans become public. Is that the 11th of June, did you say?
It is 11th of June. I hope that Kira will send you, if I can send here the link, I can share where you can see the launch, but from 11th of June, the document will be available on our website.
That's fantastic. Thanks so much. Thank you, Anya and Vladimir. That was a really fantastic section of the presentations, and leads us really nicely over to my colleague, Michelle Rentz, who's going to talk to us about how we can put some of these actions into practice. So over to you, Michelle.
Thanks a lot. So, a moment, I'm going to share the presentation. So, I hope you can see it.
Yes, we can. Thank you.
Perfect. So thanks a lot for the previous speakers, and I just want to continue with my presentation regarding also the topic Anya had, because we in Austria also struggle with a lot of problems you mentioned in your presentation. And so I want to give you all a short overview about our EU project called HacitNet, which focuses on the sustainability in the healthcare sector, and where we as Health Agency of Lower Austria are focusing on heat protection in long-term care. So a short overview about our organization so that you know what we are doing. So we as Health Agency of Lower Austria are responsible or are an umbrella organization of all hospitals in Lower Austria, so 27 hospitals and 48 public nursing and care centers. And we want to ensure a modern and need-based medical and nursing care around our region. And how are we doing this? We, as Initiative Health Across, we are a department of the Health Agency, and we are working a lot on international and European projects to bring different experiences to Lower Austria and to work together with other countries and to improve healthcare in border regions. And so with that, we have a lot of cross-border and international projects, as you can see in the overview here. And the project I would now like to present you is the project HacitNet. It's an alpine space project where we work together with 10 partners from the EU on sustainability. Here you can see our consortium and our strategic partner with which we are working together. So we have the lead partner Promise from Italy. We have Austria with us in Lower Austria and the university in Carinthia. We have Slovenia, we have France, we have Germany, and also we have Switzerland in our project. And so what are we focusing in the project? Our objective is to improve healthcare in the topic of sustainability. We are focusing on the one hand on green and e-hospitals, on optimizing the entire healthcare system in sustainability, and also, of course, to transfer knowledge and technology across us as project partners and also with our stakeholders. For doing this, we have different methodologies to engage our stakeholders. These are created by us as project partner, and we call them Policy Parley, Caravan, and STEM Lab. A short explanation you will see in the following slides, because when we prepared our project, we also thought about how can we work on these three big topics. How can we break it down and make actions? And so we divided it into 3 work packages. So the first work package was to develop a joint innovation framework together with all project partners so we can compare the different problems and solutions we as project partners in the different countries have. Then in the next step, we are focusing on the problems we had and how to solve them with pilot actions. And then in the third work package, we are focusing on how can we bring our project, our knowledge, and our pilot actions further to other stakeholders, to other countries and interested people. And so when we started with the first work package, we tried to engage different stakeholders, the ones that belong to the approach or the approach of Caravan, are trying to bring innovative technologies and best practices directly to the health and care workers, to administrative staff and also to industry and citizens. The project partners working on STEM Lab are co-creating technology, are testing different technologies, and refining the innovations tested with the end users, so with the health and care workers in the facilities. And then the third part of our project is the Policy Pali project, where we are forcing the dialogue between the healthcare professionals and the policymakers and decision makers together with the citizens and other stakeholders. And also on the presentation, you are seeing the service concepts we worked out. So what does the theoretic means in practice? How can we reach health and care workers, administrative staff, policymakers, and end users? So these are the concepts we tested. And to the results we gained is that what are the challenges of the health and care systems across our project consortium and in the Alpine regions. So we made interviews with over 100 of stakeholders. What influences the health and care system the most in the topic of sustainability? And I think in most countries of you, it will be similar. So we have the big problem of the workforce challenges, the accessibility and infrastructure of sustainability innovations. We have the demographic changes, the lack of digitalization and innovation in healthcare area, especially in long-term care, and of course also the economic sustainability and policy challenges, the standardization, and the prevention and health promotion. So, and now to come back to my main topic of the presentation, so heat protection, long-term care. This was the baseline we worked on. And we looked at that problems and thought about how can we take these challenges and make a change. And so in work package 2, where our pilot action took place, we made a concept which looks like this. So we defined a piloting zone, which was the Health and Care Center Health Across Midtgrund. This is a cross-border healthcare center where Czech people and Austrian people can go to doctors and therapists and there make their appointments. And we made together with the healthcare center sustainability check and analysis on how can we focus or how can we make actions to the challenges we define in the healthcare center. And based on the results of our challenges and the interviews, we saw that a big problem in Austria, especially in Lower Austria, is the heat. So the challenges of heat for the doctors, nurses, residents, and patients. And so we tried, or we are trying to create, together with our healthcare center and with a nursing and care home in Lower Austria, a 4-season heat protection program. This program should focus on heat protection the whole year because it's not a seasonal problem that we are focusing only in the summer month, because when we are thinking about heat protection during the summer month, it's already too late. So we said we want to make a whole year program, which I'm going to explain you the next slides, so that we can help the residents and the staff members of the healthcare center and the nursing and care home. we are creating this program, then testing it the next month, and at the end of the year we are adjusting the program based on the feedback we are gaining from the staff members this year. And because only a program can't help to reduce the heat in our facilities, and also, as Anja already said, we have a lot of problem with the active cooling. We are trying to test passive cooling oases in the nursing and care home, and trying to figure out whether it helps or if there is a need of more actions to help the staff members. So here you can see on how we are going to, or how we are preparing our heat protection program. We already made analysis and assessments together with the two facilities to find out where the main problems of heat are in the organizations. Then we made the development of the program. So we made a structure, we did literature research, we did interviews, we contacted stakeholders, and also organizations who are offering innovations. And together with them, we designed the program. Next week, we will do the on-site training with the staff members, and then they will, so we have already summer temperatures in Lower Austria. So within next week, they are starting testing our program during the summer months. And then in autumn, we're going to make the adaptation of the program, again, collecting some feedback of staff members. And in the end of the year, we're going to hand over our program on the one hand to our testing organizations, and also we want to spread it over more nursing and care homes in Lower Austria, because we think that this program would help a lot of organization and health organizations in Lower Austria. And here I'm going to present you the draft of our program. So at the beginning, we looked at the situation, especially in Austria and Lower Austria. So how is climate change influencing the heat and the problems of the health and care organizations? How has it changed over the years? And also then we tried to explain in an easy way on what does heat do to the body, and especially to the body of elderly. So why do elderly have more problems with heat than the younger people? So what should the staff members look for? And also, what are symptoms when it comes to heat? We saw when we made our research, because we thought heat protection program, it's so common, and there must be a program for the health institutions, because the topic is so important. And we found out that there are many documents and many guidance for heat protection, but all of them are documents with over 150 pages, and they don't fit really in the work of staff members of nursing and care homes or healthcare centers. And so we tried to break everything down so it's easy usable for people working with the program. So this is a short introduction about how and why our heat protection program is important. And then we come to the analysis of, for example, here you can see the analysis of the nursing and care home we decided. So the results of workshops and interviews we did. So how is heat affecting the staff members, and where it is important to set measurements. And then we created the 4-season concept. So we created the season spring. And the season spring is not like the typical spring, January, February, March. It is how the staff members feel it. So how, until which month it's okay in the centers where heat is no problem. Then summer are already the months where it comes to days where it's over 30 degrees in the nursing and care home, for example. And this already starts in April and May and goes until September, October. So in spring, we are going to prepare everything so that we are ready for the summer month. Then in autumn, which will be around October, we will evaluate the measurements that had been taken during summer. So how did they work? Did they work, or have there been measurements that had no effect or didn't work out the way it planned? And in winter, we are planning how can we adapt our program for the next year. So which measurements can we adopt or add to bring a bigger value to the center in the next year. And then in our program, we got the description. We got the description of the season, of what to focus in the season. And because heat does not only affect the nursing and care, but also affects the whole facility. So it also affects the management, the administrative stuff, and the kitchen stuff, and also the facility management. So every one of the workers in the nursing and care homes was included to together work on measurements. And then we divided the measurements, or we structured it on how they belong to which category. So organization, nursing and care, kitchen, and facility management. And we also made suggestions which measurements they can do or on what to think about. And we focused on this program to do it as easy but as professional as possible, so that they can use this program directly in their daily life. After the suggestions and the overview about the different season and possible management, we also have attached, it's called our measurements list. These are just some documents that should help the nursing and care home, or that they can just take and use. So there are checklists, there are info sheets on which, for example, which illnesses has which causes, which are the which effects has heat on the illnesses. There are info sheets that they can print and put on the door, also for the residents, for the residents and visitors of the nursing and care homes, and also stuff like, for example, the drinking protocol, so that the resident or a staff member can just check how much has the resident drank today and how much should they drink. And all these together is our program of heat protection in our nursing home. And just a short info about our cooling oasis, because we talked about passive heat protection measurements in the previous presentation. We are trying to test cooling clothes. So we are testing cooling vests that the nursing and care staff and also the kitchen staff can put on to cool their bodies down, and also stuff like cooling towels and cooling bandanas, which should help the bodies to lower down their temperatures. And also especially for the residents in our nursing and care home, we found different solutions like cooling sheets, so that you can either put the cooling sheets under the resident in the bed, or also over the residents in the bed, in their bedroom. So, as to say, these are examples for measures we are testing this summer. And so, if we will make a follow-up workshop at the end of the year, maybe I can give you an update on what worked good in our facility and where we need to make adaptations. And here again, a short summary of our pilot actions. So to come to an end, what are our results we made in the previous month, and what are the services we tested? So we found out that when we work out the program in a co-creation setting, it has a very strong engagement from all staff members. So we included the facility management, we included the workers from the kitchen, we included nursing and care staff, but also the management staff. We bring them together on a table, and so they can discuss on the topic from different point of views. And we say that also the low threshold inventions have a good exception from the staff members, because they can see we are interested to help them, and also small interventions maybe can help them. But of course, we got also lessons learned, like especially in summer month, there is limited time of staff and also capacity, and also the bigger active cooling measurements, like technical measurements, require a long preparation time and costs a lot of money. And so that's why we are trying to involve all staff groups to find measures that can react better. And also the seasonal approach, that you focus on the topic of heat the whole year, has a good acceptance across all the stakeholders and people we talked with about our program so far. And I know time is running, and I don't know how much time we get left, but I would like to share some discussion points together with you as participants, and also with the previous speakers, so that you can also share your experience on heat protection. So maybe Rebecca, you can tell me how much time we got left.
Michelle, that was really great times, because we have come right up to the coffee break. So what we will do is we will hold these discussion points for after we come back from the break, and after we've had our next two presentations from my colleagues Dua and Taya. Thank you, Michelle. That was a really great run through of what would seem quite a practical approach to how we manage some of these heat challenges within our social care environments. I did have a question around the passive cooling, but you answered it already, so that was great. What we will do is I will take these discussion points from you and hold them for our 20-minute Q&A session that we have later on this morning. So thank you so much, Michelle. I Really enjoyed your presentation. And now, colleagues, we have a 15-minute break. Go, enjoy, stretch your legs, get some steps in, get a brew, and I will see you back here at 11:20 for Taya and Dua to talk us through their next presentations. See you all soon. Welcome back, everybody. I hope you've managed to get up and have a bit of a stretch and a walkabout during that little break and are refreshed. It is great to see so many of you are still here with us today to continue with our discussion around how we support people to live well during the high heat that we are living with currently and expecting to increase into the future. So following on from Michelle's presentation in relation to how we support cooling within a situational environment, my colleague Dua Al-Assad is here to talk to us about personalised cooling solutions. So thank you very much for joining us today, Dua, and over to you.
Thank you. Can you all hear me very well?
Yes, you're great. Thank you.
Perfect. Okay, so hi again, everyone. I hope everyone is rested, well caffeinated, and ready for the second part of this webinar. So my name is Dua Al-Assad. I'm a professor at KU Leuven. I am situated within the Measure, Model, and Manage Bioresponses, or in short, M3 BioRes lab here at KU Leuven. And I am personally leading the research on microenvironmental control for human health. So in my research line, what we focus on is really trying to understand human physiological responses, but also psychological responses, and how we can model these responses and integrate them into the design of precision technologies, such as personalized cooling strategies, to combat environmental stressors that can be resulting from climate change events like heat waves, but also it can be due to air pollution, noise pollution, so an entire range of environmental stressors. And the focus of my presentation today will be on heat waves, and I will be providing you with technical evidence of the performance of personalized cooling solution and their ability to reduce heat stress, heat strain during heat wave episodes, and how we can apply them to care facilities, so how we can move from technical evidence to policy application. So starting off, I think Kira and Vladimir already mentioned this. So climate events and global warming are no longer occasional events. They are part of our daily lives. They are something we need to face and live with every day. So they bring about a lot of occurrences of disruptive events, such as increased wildfires, droughts, floods, typhoons, cold snaps, power outages, and particularly heat wave, which is the focus of my presentation today. So the way we define heat waves here in Belgium and in general is a heat anomaly. So it's a heat episode where temperatures will exceed a certain threshold that is country or climate dependent, and it will exceed it for a certain amount of time. I mean, just last week in Belgium, whoever lives in Belgium or maybe in Central Europe, we have experienced a heat wave, and we're just entering June. So it was quite an intense heat wave where temperatures were exceeding 30 degrees. In some places in Paris, it was exceeding 34 degrees. So it is quite alarming. And heat waves do not hit everyone in an equal way. We have groups that are more vulnerable than others, particularly elderly people. So when it comes to the elderly, if we look here on the graph on the left-hand side, this is the mortality rates of different age groups during the August 2022 heat wave. And we see that the mortality rates for people aged 80 and above are twice as high as the mortality rates for people that are younger. And why are older people more vulnerable? When we grow older, unfortunately, we do not stay as healthy and equipped to deal with the heat. Our thermoregulatory response will decline, particularly our ability to reject the heat from our body via vasodilation. So what happens often, especially under extreme heat conditions, our body will store the heat. Our core temperature will keep on rising until we get heat stroke, or heat syncope. And the additional thing with elderly people is also their perception. Their perception of the heat is not the same as us. So they have like stunted perception. So what is perceived by you as really, really hot for the elderly maybe will not be perceived in the same manner. So they cannot really react or take action just like we can. So That's why also they are way more vulnerable. So while we have heat action plans in Flanders, in the Flemish region in Belgium, I believe we still need scalable and low disruptive measures that can reduce the thermal burden at the personal level. And I will show you why in a minute. So what do care facilities already do? They have hydration rounds. So with elderly people, they have a lower natural thirst sensation, so they are less likely to hydrate compared to younger adults. So it's really useful, I think, as Michelle mentioned, to have hydration rounds and to track these hydration rounds. We can close blinds. We can benefit from the shading that is available in these facilities. We can open the windows during night to benefit from natural night ventilation if the diurnal temperature differences are acceptable or are large enough. We can limit physical activity, so we can reduce the metabolic heat production and overheating due to behavior of the residents. Monitoring vulnerable residents, especially frail people, is also quite useful. Providing cooler zones or cooling rooms for the vulnerable residents to shelter in case of a heat wave. But there remains, again, a lot of challenges here. So we have these already action plans that we can do, but there are remaining challenges because elderly care facilities, especially in Belgium, are quite older constructions, and there's some glazing in them and high density spaces. So some rooms, despite taking certain passive, let's say, strategies, they can still overheat. Moreover, not every resident is mobile enough to move to cooler spaces. So this leaves them lying in their, let's say, in their rooms, unable to seek help. There's a shortage of staff, at least in Belgium, and I know in Germany, there's shortage of staff in care facilities, and especially due to working conditions. So they cannot be expected to constantly be able to be present everywhere and to provide one-on-one cooling. When it comes to building upgrades like air conditioning units, not every care home has it. So, and these upgrades take time and money, so they are not on the short term. They are more of a long-term plan, and also they are energy intensive, and they contribute further to the urban heat island effect. And they do not contribute to reducing the heat waves, but they compound its effect. And also, people are very different. Everyone has individual needs when it comes to cooling, when it comes to how they perceive the heat, and this is where personal cooling device can become really interesting. And I'm not saying they are a complete replacement for existing heat action plans, but they can be an additional tool that can be integrated within them. So in today's presentation, I will define to you also what is personal cooling, in case none of you maybe you don't know of it. So when personal cooling, unlike conventional systems like air conditioners that condition an entire space, even the unoccupied areas, which makes them energy intensive because not all of the space is being used, they do not tend to individual needs as well. While with personalized systems, we focus the cooling or the conditioning to a certain small area of the space, and that is the person. And these kind of systems are also user-friendly, and you can also control them yourself. So they offer a certain degree of freedom, which can improve further the aspect of perceived control and comfort. And because they are so localized, they allow the background conditions to drift. So that's great if there's a heat wave where temperatures are exceeding 28, 29, 30 degrees, because we don't care about the background anymore because we are really focusing on the person. Thus, they can have an energy saving potential. And because they are so small, they also can have a lower environmental impact. So what we wanted to see here, so I'm showing you some examples of personal cooling strategies that you have used or you have encountered in your daily life. We have the humble desk fan that you can use, that you can place on your desk nearby, that can blow air to sensitive areas like the face, the neck, the chest, and that's where there's a lot of density of thermoreceptors that can offer convective cooling, so to increase in the segmental heat losses in those areas. We have the neck fan. Here there's a mistake. It's a neck fan, not a desk fan, which blows air at the face of the neck. This is a great option if you're on the move. So if you're, let's say, your staff or working in a care facility, you're busy doing something, you're being cooled as you work, so you don't have to think about holding a desk fan around you all the time. Equally are ventilated jackets. Maybe they're not the most fashionably aesthetic tool, but they really target the back. So that's a large surface area of the body where cooling can be quite beneficial to provide comfort. due to evaporation of the sweat at the back. And finally, we have cooling mattresses, as I think Michelle was also talking about, where we have cooling mattresses that are ventilated or that are equipped with, let's say, phase change material that melt, and they can also reduce the problems related to sleep disruption, which can also impact our mood, our ability to tolerate the heat in the next day. So the research question that we wanted to answer in this project was, could personal cooling reduce heat discomfort during heat wave conditions in these kind of spaces? And if so, by how much? So we wanted to really quantify how much reduction in the discomfort and the heat strain that these kind of systems can bring under simulated heat wave conditions. Now, the study that I will show you was a testing that we did in a common area in an office, but these results can be easily taken to care sector pilots because the conditions we simulated are quite diverse. We had young people, old people, males and females. So these findings are starting points, but not a direct replacement for care-specific evidence. So for the sake of not being too technical, I just had one slide on how we achieved, how we did this study. So we had an office model with different people. So you can see here the people sitting. So that can be also a common area in a care facility. You have this common rest area where people do activities, where they eat together. And we allowed the people in this office model to either use personal airflow at the face, personal airflow at the back, or combination of both. And we also kept some people not using anything at all. And these people can be a reference case to compare how much discomfort reduction can be brought about by using these personal coolers. So the occupants were also modeled in a thermophysiological way, so we can know what is their response to the heat event that we are simulating. And we can know what is their core temperature, what is their segmental skin temperature, and subsequently we can predict with comfort models that we develop how much a reduction in the discomfort we can obtain when using these personal cooling devices. And the comfort models that we are using are a qualitative categorical scale from -4 to +4, where -4 is very uncomfortable, where +4 is very comfortable. So we will see later on in the results section how the use of these personal systems can reduce the discomfort. And the heat event that we are simulating is a typical heat wave event where temperatures are gradually increasing due to an outdoor heat wave, reaching a maximum of 31 degrees in this common area. So going about now to the results, what we obtained. So when it comes to the occupant's personal environment, we see that there's an increase in the velocities at the face for the people using the personal airflow to around 0.3 to 0.6 meter per second. This depends on how fast or what is the setting of the fan that the people were using. And we see for the back, there's also an increase in the velocity to around 2.5 meter per second, which is much higher than that at the face. And the reason why we choose higher velocity at the back is that at the face, you have the eyes that can dry out, so you cannot really go too high with the velocities. So how does this reflect on the overall comfort of the people that were in that space? So in this graph on the left, you see the people that were not using any personalized cooling strategy. So they were just relying on the background ventilation or even if there's no background ventilation, they were sitting in this warm space. And we had an old male and an old female. And you see the comfort is in the negative scale. So we have uncomfortable conditions due to the heat wave. While if we look and compare with the people that were using a personalized airflow at the face, we see a reduction in the discomfort from uncomfortable conditions to slight discomfort. Even here, you can say there's a neutral feeling with the young people. And you see the older are a bit more uncomfortable than the young that were using these personal airflows. And that's because with the older people, they store more heat, so they cannot get rid of the heat as fast, but still you have this reduction in the discomfort. And interestingly, when we look at the people that were just using the fans at the back, we noticed that there is a really fast decrease in their discomfort, and which at the end turned to comfort conditions. So people were actually happy with the space. They were feeling well, and they can probably function in the space under these conditions. And again, older people were less satisfied, but you still have a reduction in the discomfort. And when we combine these two airflows together at the face and at the back, it's a bit more interesting here, the results. Like you see that people will only find it comfortable after 15 minutes of use. And that's because there's two very strong airflows coming at them, so it can be a bit uncomfortable, too cold, maybe even when the temperatures are still below 28 degrees. So before 15 minutes, the temperatures were below 28. So we would recommend to use these combinations, like this extra protection of both airflows, only if temperatures are really high. So if they exceed 28 degrees and not immediately, where in that case, it's better to just rely on a single airflow, which is more than enough. Now, why this translates well in care facilities? So older and more vulnerable residents that may not regulate heat very well, as you saw, they can reach conditions of comfort when using these personal cooling strategies. And an additional benefit of these strategies is that they are accessible, they are portable, they are cheap also and intuitive to use by both the staff and the users themselves. And here in care facilities, we cannot forget about the staff as well. They also experience heat stress, especially when, and it's critical because they really have to perform and provide care in such strenuous conditions. So younger staff can also use these kind of devices, such as I showed you in the beginning, the neck fan, to improve their working conditions. And also, in rooms in care facilities that overheat more than others, perhaps rooms that have more glazing, rooms that have higher occupant density, or that are oriented to the south, for example, these personal cooling strategies can be quite interesting because they work quite well in overheated spaces. And they can provide targeted protection to vulnerable users. But again, with every kind of system that we integrate, we have to consider practical implementation in the context that we are interested in, which is, let's say, the care facility. So we have in the frailty and medical condition of the people that reside there. So if they are on medication, if they have chronic disease, their thermoregulation capacity is not the same. They may need more cooling. So we have to take that into account and understand for each person what are the needs related to their health, their personal health, and adapt the operation of these systems to their conditions. We have the hygiene and cleaning of these devices. So I think all of you, if you've ever used a fan in your life over time, and if you don't clean it, it will gather up dust. And I'm guilty of that myself. And in a care facility where old person maybe that has some chronic pulmonary disease, you cannot just keep blowing dust at their face. So it has to be regularly cleaned and maintained. Another issue of, especially of convective-based devices, so fans that produce a lot of airflow, have the problem of noise. So people that are using them, even if they are feeling comfortable, they will turn them off if they're too noisy. So care has to be taken when designing these fans to the noise issue, because that can impact. Coming to the fourth point, this can impact how people accept these devices. And on top of noise, there are acceptability issues regarding ergonomics and aesthetics. It cannot be ugly. So if, let's say, it's a bulky fan, it's really like metal, and so people are less likely to accept it in their space and less likely to use it. So it's a framework that integrates not just environmental aspect like noise, air quality, and comfort, but also it has to be aesthetically pleasing, and so ergonomics and functionality have also to be considered in the design in the design of these systems. Now, when it comes to implementation, it's always the question, because they are personal devices, who is the person that operates them? Do we give the operation fully to the staff? Do we just let the users handle them? Who maintains them? Who cleans them? So there's also questions of that. Also, how many do we need? Where do we place them? When do we activate them? If there's a heat alert, do we activate them proactively, or do we wait till the heat alert to happen, and for how long? Also, what kind of training is required to operate them? Is it just a button that we switch on, or do we need to understand more what is the impact on the health, the individual health of each resident? So the next steps would be to test the strategy actually in a pilot test here in Flanders, where we take 3 to 5 case studies during a warm period, and we implement these personal cooling strategies, and we look at the evidence before a large-scale rollout, and also to learn practical implementation lessons by talking to the staff, by talking to the residents, to be able to provide individualized, better protection of the vulnerable users, and also to provide knowledge to the staff to be able to personalize the operation of these strategies to tailored to the tolerance, physiological and psychological heat tolerance of each resident. And finally, based on this research that we did, we saw that personal cooling can indeed add a practical layer to heatwave preparedness because they are able to reduce discomfort under heatwave conditions. Not only this, they are able even to provide habitable and comfortable conditions during heatwave events, and can help protect people, especially when the room level cooling is limited or in some older buildings even non-existent. So the benefit of these strategies is that they can really handle individual strain. They offer the ability of personal control. They target the cooling to the segments of the body that are most sensitive to cooling. But of course, the next step would be the evidence-based, as I previously mentioned. So to pilot test them in care facilities before a large-scale rollout, and to eventually integrate them as part of existing heatwave action plans. And the most important things to evaluate, as I mentioned, is the perception. So with the reduction in discomfort, safety, hygiene, usability, how much workload do you add also to the staff when you use them, acceptability, and of course the energy and environmental impact of these systems. And one more point I would like to make, maybe a bit controversial. We always, when we talk about heat waves and when we talk about heat adaptation, we treat human beings as a constant boundary conditions. However, human beings are quite adaptable. So if people over time are exposed to these small doses of heat, eventually they will adapt their thermophysiological response by reducing their heart rate, their core temperature, by also sweating more efficiently. So also a practical aspect from a proactive point of view to heat adaptation is to also let people adapt to the heat. And of course, this is quite applicable and has been proven in lab studies for young people, but evidence has to come also for elderly, because this is not so straightforward for these people that possibly cannot adapt, and the evidence is still missing there, but it's something to consider. And when considering this, it can also be part of the design of personal cooling strategies and how we operate them and for how long we operate them, to be able to benefit from this short-term relief in the heat strain and also balance the long-term heat adaptation. So with that, I would like to end my presentation, and I would like to thank you all for listening, and looking forward to any questions you may have. Thank you.
Lua, thank you. That was fantastic. And I love the fact that you've given us some really practical steps that we can take in the here and now, really, in terms of how we support people, particularly within that health and social care sector, to be able to live well during those heat waves that we have. I'm much further north in Belgium, and we certainly had a big heat wave this gone week. It got to 32, I think, here in the UK. Yeah. And we are not used to heat. We do not adapt well to it. And that point you made around how do we enable older people, particularly within that health and social care setting, to adapt in a managed way, I think is a really interesting one, and not one that I've heard posed before. So I'm grateful to you for posing it here, because it's certainly one for further consideration. But further to that, I wanted to ask a question. So you talked about the gap in terms of understanding how we support people to adapt to physiologically, but in terms of the biggest remaining gap in current heat action plans, where do you think that sits? Is it in building, staff capacity, resident vulnerability? What's your view on that bit?
I think if I can summarize this as one point, is communication. So we have these so there is a lack of a systematic, structured way to respond to the heat. So let's say there's a heat wave that happens. What is the first step that I need to do? When do I start to prepare? So I think, first of all, there needs to be a way to communicate to staff and to facility managers, adapted, of course, to how their understanding of, first of all, what to monitor, where to monitor it in the space, in the care facilities, to understand, okay, this is the point where I start to need taking action. Is it when the temperature exceeds 26 degrees? Is it when it starts to exceed 28 degrees? So that's the first step. And once you know what to monitor and how to monitor it in a good way, then you can go to proactive actions, and that would be to also share the knowledge on the health capacity of these different elderly people, or like for example, and we need to really understand. So we have people, for example, that physiologically they cannot deal with the heat at all, but psychologically they're fine with it, but that's not okay. So these people need to be treated differently than people that physiologically are okay, but psychologically cannot tolerate the heat. So you see, there is this really complicated knowledge that still needs to be discovered when it comes to understanding the tolerance and communicating this knowledge to the staff and to the facility managers and integrating this knowledge into the operation. So it's along the chain. So it's indeed to communicate if I can resume it in one word, it's to communicate effectively to staff, and also trying to integrate the needs of the staff into these heatwave action plans, because you need to create more attractive working conditions for these people so that they can keep caring for or keep being motivated to care for the elderly. So.
Thank you. You make a really good point about motivating staff to continue working in those sectors. When we know that actually our recruitment to those sectors, in the UK certainly, I don't know about elsewhere, is already significantly challenged. So how we make that an attractive working environment to people, I think, is really important. So thank you, Dor. I've really enjoyed your presentation today.
Thank you for the
Appreciate
opportunity.
it.
Thank you.
I would like to now welcome to the floor my colleague Taya Jankowski, who's going to talk to us about heat and health protection for the outpatient sector. So shifting sectors slightly, but still very much focused on how we support people within that health and social care sector. So Taya, the floor is yours.
Thank you very much, Rebecca, for your kind introduction. I hope everyone can hear me.
Yeah, you're great.
Thanks very much. So Teja Jankowski is my name. I work at the State Coordination Center for Heat and Health Protection, which is located at the State Office for Health and Occupational Safety in the state of North Rhine-Westphalia in Germany. And as you mentioned, a shift yet in the presentations. I will be focusing on heat and health protection in the outpatient healthcare sector, in particular on the development of practical guidelines for outpatient healthcare providers here in the state of North Rhine-Westphalia. So in comparison to the previous presentations in our project, we are at the early stages of this project. These guides that we would like to develop will complement existing guides that my colleagues and I have developed for heat and health protection in the inpatient healthcare sector here in the state. So next slide, please. These existing practical guidelines for helping healthcare facilities in the inpatient healthcare sector develop heat protection plans. I presented these last year in September at our conference in Brussels. And these are guidelines that we made that are specifically to support two very specific types of healthcare facilities develop their own heat health protection plans. So there's a version for hospitals and a version for residential care facilities. The overall aim of these guidelines is to strengthen the heat resilience in these specific healthcare settings, and also to protect the vulnerable people that are being cared for in these settings during extreme periods of heat. Next slide, please. And just for those who weren't able to take part in the conference last year in September, to give a very brief overview of these existing guidelines, which we've already developed. In Germany, there is currently no legal obligation for healthcare providers to develop heat protection plans. There are, however, many different recommendations available in Germany, as well as calls for action from various healthcare institutions here in Germany to create heat protection plans in healthcare facilities. And our approach here in the state of North Rhine-Westphalia is to create modular guidelines that healthcare providers can use and adapt to create heat protection plans that are very specific or very much based on the structures and capacities of a hospital, for example, or a residential home facility. And another very important approach which we take in our state coordination center is that we develop these guidelines in a collaborative process with various stakeholders from the healthcare sector and the public health sector themselves here in the state. Next slide, please. So just to give a brief introduction or overview of this modular structure, which we have in our existing guidelines, they are divided into 3 sections. So there is a checklist which gives a very quick overview of all the modules that are available in the guidelines. There's background information, which gives basic information on climate change and health and heat risk factors, background information in general to, for example, the German heat warning system and how to use the system in facilities. And then there's a section called measures, which is very context-specific information on how to take action during heat waves. So there'll be information in this section on how to properly store heat-sensitive medications, giving information on how to maintain an adequate fluid intake during extreme periods of heat with patients, and also how to cool indoor areas. Next slide, please. So now we come to the new guides, which we are planning to create with this information of the previous guides in mind. It's currently largely overlooked that the outpatient healthcare sector in Germany, that there are specific guidelines available for certain healthcare providers in this setting, such as for nursing services, which are providing care for people in need of care at home, as well as medical practices who have regular contact with vulnerable patients. Which is why we have decided to develop new guidelines, which are very closely based on the approach of the previous guidelines, but we want to develop them further and focus then with these new guidelines on outpatient healthcare providers. And the aim then with these new guides is to strengthen the heat resilience in these specific healthcare settings, as well as to provide the vulnerable people, as well as the workers in these settings from extreme heat. Next slide, please. So to give a little bit more context in the German scenario or the German setting, the outpatient healthcare sector here in Germany is one of the largest and most important parts of the German healthcare system, and it is a very patient-centered system. So most vulnerable individuals, such as older adults or chronically ill or those care-dependent people, live at home rather than in a healthcare setting, such as in hospitals or in care facilities. It's roughly 86% of those in need of care in Germany are being taken care of at home by nursing services or from being taken care of by relatives. At the same time, these challenges were already mentioned in previous presentations. Germany is also a population that is aging rapidly. There are an increasing number of high-risk persons or high-risk patients that are receiving care outside of residential care facilities, outside of hospitals, for example, which means that outpatient care providers are also increasingly on the front line of climate-related health risk prevention, and therefore play an extremely important role in reaching these vulnerable groups, which is why we see there a strong importance to strengthen the heat resilience and protection in the outpatient care sector, and that it's a very important public issue here in Germany as well as in Europe. Next slide, please. So in the outpatient care sector, in Germany, for example, the responsibility for heat protection is largely distributed across multiple healthcare providers. So we have, for example, the physicians, the GPs that play a very central role in medical risk management. They play a central role in identifying high-risk patients, in adjusting medications, educating patients about hydration, for example, and overall promoting protective behaviors. Then pharmacists also contribute primarily through medication management and counseling. They help identify heat-sensitive medications. They help explain potential side effects related to heat and support the overall safe adherence of medication during periods of extreme heat. And then we also have the home nursing services that provide the direct support to patients in their living environment. So that includes monitoring patients during home visits, assessing hydration levels, observing potentially dangerous living conditions such as overheated apartments. Because of these various roles and responsibilities, it's quite fragmented. It's quite a fragmented system. There's a clear recognition that effective coordination and communication between these healthcare providers is essential during heat waves. Next slide, please. So just comparing the inpatient and outpatient care sectors here in Germany in terms of promoting heat protection and integrating heat protection into existing structures, there are several important differences which we have recognized. In hospitals and residential care settings, patients can be monitored continuously, which allows healthcare staff to detect heat-related deterioration early and also respond quickly. These settings also provide greater control over the environment, and there's a clear responsibility for patient care in these settings, which makes the overall implementation of structured heat protection measures, such as monitoring or adjusting room temperatures, quite easy to implement. Whereas in the outpatient care center, the situation is more complex. The healthcare professionals usually have intermittent contact with vulnerable people. There's limited control over the home environment, so the responsibility for heat protection is divided across these various healthcare providers, which can overall increase the risk that warning signs then go unnoticed, which is why we see in the outpatient healthcare setting a stronger need for coordination and a more patient-focused education to promote healthy behaviors. Next slide, please. This is why we have identified yet coming up to developing these new guidelines that there are various challenges which we will be facing when it comes to developing these guidelines and to promote the integration of heat protection in the outpatient care sector. And these challenges we want to try our best to address with these new guidelines. The major issue is this subject of coordination and coordinating care between the various healthcare providers, especially when we have patients or vulnerable people who are receiving support from their GP, so from a general practitioner, from home care services, from other medical specialists, and even family members at the same time. Monitoring is also a limited constraint because contact with the patients often occurs only during scheduled visits. If it's going to visit a doctor for an appointment, or if home care is coming to visit you in your home setting. And this also makes it more difficult to detect early signs of deterioration, of dehydration, for example, during an extreme heat event. And heat waves also place an additional stress on the healthcare workers themselves, which we've also previously heard in the previous presentations. And this demand obviously increases during periods of extreme heat. And as also previously mentioned, it's also a very significant subject here in Germany because there are significant workforce shortages, in particular in the outpatient care sector here in Germany. Which places an extraordinary or a stronger demand on the workforce during heat events. Another challenge is the limited control over patients' living conditions. So healthcare professionals that come into the home of a vulnerable person can recommend various cooling strategies, but they cannot always influence how the implementation will take place when they're not there during their visits. And they also obviously cannot influence other factors such as the quality of the housing where the vulnerable patients live. And finally, of course, medication can increase heat sensitivity, dehydration risk, and that also means coordinating the medication management becomes especially important and critical during extreme heat events. Next slide, please. So despite these challenges which we have recognized coming up to developing these guidelines, we also see many different opportunities for improving heat protection or integrating heat protection in the outpatient healthcare sector. While we have, because we've identified that outpatient services, healthcare providers in this sector are very often the first point of contact for vulnerable individuals, and therefore can play an extremely important role in providing first-hand preventative support. So this creates opportunities to directly strengthen prevention through patient education, through early intervention, and through regular contact or regular communication, which can take place during extreme heat events. And at the same time, improving the heat protection or supporting the integration of heat protection in the outpatient healthcare sector can also support occupational safety for healthcare workers who themselves are also being increasingly affected by extreme heat conditions. In the long term, when we have a long-term perspective, the integration of heat protection into outpatient care contributes to building a more climate resilient healthcare system, that the system is better prepared for future heat waves and other climate-related health risks. And this then ultimately significantly improves protection for the vulnerable people themselves. So the hope would be to see a reduction in heat-related illnesses, a reduction in hospitalizations. It can help create a better continuity of care during heat waves. It increases the patient's safety at home in their home environment, and ultimately give them more independence and quality of life during heat waves. So my final slide gives a short outlook on the guidelines which we are starting to develop. We're still very much in the conceptual phase, but we have the hope that we will, over the summer months, start finalizing these guidelines, which will also be developed in a very collaborative process. So we will also have various healthcare providers here in the state of North Rhine-Westphalia taking part in developing these guidelines with us, and also various practice partners across the state will also be able to support us in creating these guidelines with the overall aim of strengthening the coordination and communication. So this is an area where we noticed as a gap currently in Germany when it comes to various outpatient healthcare providers and the integration of heat protection, that we want to focus on how can the communication between the various healthcare providers and the coordination during extreme heat events, how this gap can be filled, and how we can provide support with these guidelines for the ultimate implementation then during a heat wave. And of course, to provide healthcare workers and the vulnerable people themselves with more heat protection. As of today, the plan is that these guidelines will be available by the end of the year. Could be the beginning of next year, but we'll see how we get on. Thanks very much for your time. I also have a few questions. If anyone has questions for me, here are my contact information. But regarding the subject, and because we're at the very early stages, it would be very interesting to hear from other regions, from other cities, if there are similar approaches, if there are similar challenges or similar opportunities that I recognized. It'd be great to hear from you. Thank you very much.
Thanks so much, Taya. That was a really interesting presentation. And now is a great time to offer up the opportunity for colleagues. If they have a question specifically in relation to that or a response, please do pop that into the Q&A chat, because there is an opportunity for coming up shortly for a Q&A session to all of our panelists. So that very nicely timed there, Taya. I have a question, if I may. So you touched on the need for coordination as quite central, I think, to particularly the management of outpatients within that setting. I wondered if there was any opportunities that you see that would be additional to that for protecting vulnerable people through that kind of outpatient coordination of outpatient care providers.
Yeah, there are already several. Maybe I didn't mention this. In Germany, there are they're called heat protection plans that have been developed for various healthcare providers in the outpatient sector. So it's available from the German Health Ministry for very specific for pharmacies or for medical practices for psychologists or therapists. And these are all these guidelines. They're very focused on the own institution or my own praxis or my own pharmacy, and the opportunity which we see or the gap that we see, which we're trying to fill with these new guidelines, as you mentioned, is the communication, the coordination between these various institutions in a plan which is directed on all these people together. So that's the hope that we have, to bring these various outpatient healthcare providers together, to put the focus away from how to protect just a pharmacy, for example, as a pharmacy, and what pharmacists can do to promote heat protection when a person comes into my practice or comes into my pharmacy, and bring it more focused towards this is the patient that I'm taking care of, and how can I take up communication with the doctor or with the nurse providing home care support, that there's an overall coordinated protection which is more patient focused. So that is the hope, that when we strengthen the coordination, the communication, and the preventative action in the sector, that we will, hopefully be able to prevent more an increase in heat-related illnesses, in hospitalizations.
That makes sense. Thank you very much. And what you speak to, I think, in terms of that communication, speaks back to what Dua and also Vladimir talked about earlier, in terms of actually at the core of this, we have a huge amount of the knowledge here already in the system. What we need actually is that improved coordination and communication with our service users, our staff, our workforce, between those systems, to ensure that we're making best use of the resources and the knowledge that we all share collectively. And I think one of the joys of this work and bringing colleagues together is there is clearly a huge amount of work already underway across the cities and the regions in relation to how we support people live with the high heat that we're experiencing and that we will experience into the future. And this is one of the great things about this process, is it enables us to share our work and learn from colleagues. And I know I've certainly learned a huge amount here today, and we'll share that learning within Wales and wider. So thank you. We are now moving into our general Q&A session. So thank you to all of our presenters who have contributed. We are now going to move into this session. So colleagues, please, who are on the call, please do pop your questions into the chat, and I will read those out to the panelists as we go through. I'm going to start with one of my questions of my own, though. So anybody is free to answer this. Please do just unmute yourselves and speak. But one of the key themes that from colleagues' presentations is the need to ensure the health of both the patients and the workforce. And I think Taya talked about that kind of occupational resilience and how we support people to deliver healthcare well. What do colleagues think are the key factors that we need to consider in terms of kind of keeping health and social care staff safe during these extreme heat events? Noting that actually they will have their own challenges and vulnerabilities themselves as workforce providers. That's to anybody on the call who might like to come in.
Maybe I can start.
Please do.
So I had mentioned that we had developed heat protection plans, or the guidelines that were specifically made for the inpatient care sector, so for hospitals and for residential care facilities. And in these guidelines, which we developed around 2 years ago, we actually never looked at the workforce and protecting the workforce in these settings in terms of heat protection. We were always looking at the patient themselves, in terms of how can we promote resilience. And that's the goal which we have with the new guidelines, is to bring this this aspect more in focus. And not only will we address with the guidelines the people, the workforce themselves that are implementing the measures to protect the vulnerable patients, but also the people that are in charge of, for example, planning the route. So for a nurse that has to visit various people at home throughout the day, the people in charge of making the planning behind these behind the tasks, or how do I go from A to B to C? So for one person to the next person, if it's possible to maybe look at changing the times, the schedule when I visit healthcare, the vulnerable patients, to protect the workforce themselves from driving around during the midday sun. Smaller tasks, or tasks that involve not only the workforce themselves doing the implementation, but also the owners of, for example, a nursing care nursing service, or that are on this level above. I can't think of the English word right now. But that's also a focus which I think is also a key factor, is also looking at the level above the workforce. How can the level above them also implement measures in terms of planning the routes or planning timetable schedules, working schedules to also protect the people in the workforce.
Yes, that absolutely makes sense. It really does. And it's something, because where I work in the north of Wales, in the United Kingdom, it's quite a rural patch. And actually, travel time is a key challenge, I think, for how we support staff to get to all of their visits that they need to do across that rural region. And so I think it's when we're talking through these solutions, we can speak of it from either a city where we have like quite a condensed urban conurbation and travel times will be much shorter. But the challenge will be different, won't it, in those more rural spaces, and how we manage and enable some of these interventions when you have increased travel times and rurality will be different. And it's important that we factor that in also. Thank you, Taya. I really appreciate it.
May I
Well,
add, may I add
oh,
something here as
please,
well? Yeah,
please
because
do.
Thea, you mentioned indeed the transition, and this is something that actually we are interested in, is the resilience of transportation, of public transport. So also, I don't know how it's like in your countries, for example, in Belgium, if you're taking the public transport, which is not so frequent sometimes in certain areas, these buses can be very, very hot. So I one time almost fainted like in a bus because I just needed to get out. So also we need to take care that during these transition routes that they have enough cooling also in transient environments, whether also they're in their cars. A lot of cars don't have air conditioners, or if they have air conditioners, they are operated at really low temperatures, which if you also transition to a hot environment, that cannot be good for your health as well. So also or adaptive strategies during transition is also can be also useful to consider.
Yeah, I completely agree. Public transportation within the United Kingdom is very variable, I would say, and we have some great examples of where it works well, and we have quite cooled environments. But particularly in our more rural areas, and we talked about that travel time, the reliance on public transport is really limited, and actually how we support personal vehicles in that space and where we're able to more active forms of travel, it is really key and quite insightful. You mentioned an element in relation to the transition doer. That's not something I know a huge amount about. Are you able to talk us through a little bit more about the if you know the physiological challenges of moving from a particularly cold to that transition? What can that challenge to the body physiologically?
So for example, if you're, let's say, moving like your car is air conditioned at 15 degrees, often that's the case. And if you move to an environment which is, let's say, 30, 36 degrees, this can overshoot, let's say, your responses. And this can bring about, let's say, a really negative perception of the environment, more than what it would be the case if you move from, let's say, 26 degrees to 36 degrees. So a recommendation there would be, if you get into your car, don't like just turn it into a fridge, just keep it reasonable so that you do not really shock your body and overshoot your responses, which can take a long time to restabilize after it, which can have repercussions for maybe more vulnerable people, because the staff are also, they're not all 30 years old, they can also be 50, 60. So it can have, so also be mindful of that. Additional cooling does not bring about any benefits on comfort or how you adapt to the heat or fight the heat. So
That's really interesting. Thank you. I didn't know it, so it's great to hear that those insights. Wondered if anybody else might like to come in here. Oh, Kira, fantastic. So I can see that you're online. I wondered if you, as the kind of as our host here today, would have any insights or questions you might like to pose to the panel.
Yeah, thank you so much, Rebecca. And let me just take this opportunity to just congratulate all the panelists. It was absolutely fascinating. I think I was a little worried that we had long presentations, but I think it's a reminder that we really need these deep dives because we're all exposed to a lot of quick information these days, and I thoroughly enjoyed the intervention and the discussion. I think for me, I would even like to go back to the very beginning when we were setting the scene, because I found it fascinating that, of course, we have Petra here at the table with us, an architect, because I think what we have seen today is that, this challenge is a challenge that cannot be addressed by one sector alone, or by one team, or by one person. So I thought it was a really powerful way of setting the tone for the discussion, especially because this year we are celebrating the 40th anniversary of the Ottawa Charter of Health Promotion, which of course really stresses that health happens in the environments where we are born, where we live, where we grow, where we work. And I think Petra really spoke to that. So Petra, I think I would have a very concrete, very specific question for you, and that is, what is that magic ingredient to really sort of get all these different actors around the table? Because it's something we speak a lot about in health and all policies, but it is a challenge. We do still tend to have these conversations in silos, and of course that also goes to. I know that Vladimir had to leave, but again, really good to hear that we have these guidelines coming out, and really good to see that there's also focus on what can be done at different levels, so at the national level, but also at the regional level and at the local level. And I would have liked to have sort of heard more, or sort of unpack a little bit more what those actions are, because I think that's what we're also looking for as we move into the future. What can we concretely do? And that's what I've really enjoyed about the conversation. I really paid very careful attention to your presentation, because I don't know if you're aware, but in the WHO Europe region, we are about to take a regional strategy on healthy aging to our regional committee that will convene in October. The regional committee consists of 53 member states, and if all goes to plan, hopefully then they will adopt this regional strategy. So one of the sort of pillars of this strategy is indeed that of the physical environment, and how we can really address the environment for older persons. But you spoke about it, that we have limited evidence. In fact, we have even more limited evidence on older persons above the age of 85. So I think I think as we move forward, we'd be very curious to, again, better understand that evidence gap, but also what steps we can take to address those that are most vulnerable, including older persons, but also those that are 85 and above. So again, we'll be looking to, addressing that evidence gap, but also very concretely look at what we can do to address the needs of older adults. So just some sort of reflections, but also some questions for you, and of course that magic ingredient for getting all of these different stakeholders around the table, which of course I believe is the key to success in the future.
Thank you, Kira. Wonderful highlights that you've made. And I will be happy to answer. A great question. I was surprised when as an architect, I have no medical education, but as an architect, I was surprised that we somehow forgot about health in some, I don't know, in this production era or overproduction era or something like that. And health was not even an issue. So we have compliances, we have regulations about materials, but health somehow stepped out. I don't know where, but I see with colleagues that we work with, they're not asking these questions. So for us, it was really important. And when we addressed those questions, they were all alert. Oh yeah, that seems reasonable. Why would I I don't know, pick acrylics if I can do healthier. I didn't even know that this is toxic. So what we found out was a format that we find, I would say, the most implementable is educating events. Because if I say architecture or engineering, they have these education points that they need to have. And if we do events, they get points. So those events are something that we can, get them stimulated a bit into these questions. We work really closely with Chamber of Commerce in Slovenia. So we also did few projects, few events with them. So we address also I would say the industry sector in that term, and also for me, the most, I would say, effective way was addressing municipalities directly. So when we go to the mayor and we say, would you like to address your people with, we are building healthy, I don't know, elderly home, we are building healthier kindergarten or school or whatever, they say, well, yeah, we didn't even know that we are doing this in toxic ways. So I think the bridge between the knowledge that exists and the real implementation is actually the translation of that knowledge to the right people. And I believe that WHO is already doing this, but maybe the implementation sector is not even aware of this. So we are speaking of health on many tables, but when we speak about public projects, health is not at the table. So we try to book and put health at the table when we speak about that project. And I think that's one of the ways to do it. No magic stick, of course, for all that things that we do. But I believe that this topic should be addressed. And we are addressing a lot sustainability and environmental health and all that stuff and all the carbon neutral and all that information, which is really important. But health is not yet at the scene within construction sector and so on. So I believe that maybe translation to that is something that we can use. Thank you so much for paying attention also.
And if I may add something, because Kira, you mentioned also the evidence on the physical health of the elderly and the lack of evidence that is. And I think maybe from my perspective as a researcher, evidence starts in the lab. And if you look at what is out there so far, no one wants to approach the topic of vulnerable populations like elderly. So they rather stick to the young subjects. And I believe that's the case because ethically wise, it's easier to start there and then extend your conclusions to the elderly people. But that's completely not okay to do. I think, I think when it comes to the elderly, and this is what we are trying to do, you need to have more research in that area. You need to address a lot of issues that has to be with, like, say, the age group that they are in, the sex, the medication that they are on, and how does that impact their thermoregulation, their activity level, how do they hydrate, all of this, and how it impacts how we react to the heat, how our body responds to the heat can be quite different, and all of these individual factors need to be studied. And eventually, the key is to have this tool where you can predict this response, this output, to eventually implement or integrate into the design of any kind of strategies, whether it's passive strategies, whether it's zoning in the space, whether how we move people in a space. So I think we need to go, like, the long-term objective is to really go for these simplified tools that can tell us how a person will react, both from a health perspective but also from a subjective perspective to the heat, and try to integrate these or communicate them in an easy way, let's say a web platform with the staff of the care facility, to be able to really suggest solutions that can be tailored to each specific person.
That's fantastic. Thank you, Dua and Petra, for your insights on that specific matter. It's so vital, isn't it, how we get the design right within these spaces. And what you've spoken to really helps us to understand the importance of that. And I think the WHO has been able to show over a number of years that actually health is the built environment is really one of our founding building blocks of health. You know, how we create and build that safe environment for people to be able to live recreationally and work safely is so key to actually the health of our cells. So it really does start, you mentioned it starts in the lab, but it starts in that environment, does it, and how we build it and the things that we use to build it. So thank you both for your insights into that matter. I'm going to come to Kira now for our final comments before we close, but I would also like to say a big thank you to everybody. I've thoroughly enjoyed today and would like to thank all the participants for your time and energy this morning. So over to you, Kira.
Thank you so much, Rebecca, and thank you to all the speakers and to all the colleagues who have very kindly connected for this very, very fascinating webinar. So I think throughout the morning we have, of course, covered a great deal of ground. We have set the scene, we've defined the challenges and exploring also very concrete responses across sectors and systems. We, of course, also heard the reflections from Vladimir, and he very kindly offered a sneak peek into the WHO heat health guidance that will be launched on the 11th of June. And it's wonderful to get a glimpse into what direction these guidelines will travel, of course. I think a key message that really emerged from today's discussion is that climate resilience is increasingly a health imperative. And that's whether we are discussing hospitals or nursing homes or outpatient care, buildings, urban environments, or community preparedness. And the health impacts of climate change are already shaping the realities faced by regions and cities across Europe. I think what we've also heard is that there are solutions and they are available across different countries, different contexts, different regions, and also cities. And it's also very encouraging to hear that innovative approaches are indeed being developed to protect populations from extreme heat and improve indoor environmental quality and also strengthen care systems and create healthier living environments. I think for me, there were a number of themes that really stood out. I think first and foremost, prevention and preparedness remain essential, and investing early in heat health action plans and resilient infrastructure and protective measures can indeed save lives and also reduce pressure on health and social care systems. And I also, as I mentioned earlier, I really appreciate that climate resilience really requires collaboration across sectors. We know that health authorities, they cannot act alone. So effective responses really depend on partnerships with planners, with architects, such as Petra, and environmental agencies, but also social services, academia, and communities themselves. And that's, of course, also why we really see the sort of strategic advantage of having some very powerful networks here with the WHO, the Regions for Health, and the Healthy Cities Network, because we know that you work very closely with communities. I think what I also heard and what I also think is very, very essential is that equity must really remain at the heart of these efforts. The people most affected by climate-related risk are often those that are most vulnerable, and ensuring that adaptation measures really reach those populations in both public health is a necessity, but also a matter of social justice. And then I think what we've also seen that this conversation is, of course, very, very timely. I mentioned earlier that just 2 weeks ago, the Pan-European Commission on Climate Action and Health launched its report with 12 very actionable recommendations. And these, of course, provide a very timely framework for accelerating action across our region. And then, of course, local and regional governments are absolutely indispensable actors in building resilience. your proximity, as I said, to communities allow you to really identify emerging risks, test innovative solutions, but also translate policy into practical action and to scale this up, not just within your own context, but also amongst other regions that form part of this network. Looking ahead, I also want to just highlight the upcoming Mayor Summit. I mentioned that earlier. I think that speaks or links or connects the dots, so to speak. Petra spoke about the importance of really getting mayors involved. This is what we are doing in October, 5th and 6th of October, where we will be convening mayors in the city of Cork in Ireland that will be looking at how to localize the recommendations from the Pan-European Commission. So again, a really wonderful opportunity to again put all of the challenges that we have addressed in today's webinar and put them to the mayors and look at how best to allocate, to apply those at the local and the regional level. So I think today's webinar has really provided great ideas. Again, lots of food for thought. It's strengthened our existing partnerships as well. And I think it's also inspired further collaboration. And again, the challenges ahead are, of course, very significant, but I would also say and stress that so is our collective capacity to respond to this. So looking to the future, I think the task is to really move from shared understanding to sustained implementation, scaling what works and adapt solutions across contexts and ensure that climate and health actions becomes fully embedded in the way regions and cities plan, govern and invest. And of course, if we succeed, we'll not only reduce risk from heat and pollution, but also create healthier, more equitable and more resilient communities for generations to come. So before we close, that leaves me really to extend a very sincere thank you to you, Rebecca, for moderating the conversation so eloquently and for skillfully guiding the sessions and connecting the dots across this or across today's deep dive. And of course, a huge thanks to all of our speakers for your excellent contributions today. Petra, Vladimir, Anya, Michelle, Dua, and Thea, really fascinating presentations. You've given us lots of food for thought, and now it's up to us, of course, together and collectively to make sure that we put all of that into practice. And then a huge thank you to all of our participants for your active engagement, for listening and for being with us and taking time out of your busy schedules to be with us today as we take this into the future. So with that, thanks for me. Back over to you, Rebecca.
Thanks, Kira. And thank you, everybody, for joining us today. Just to let you know, we will be sharing the slides where we are able to. There may be a slight delay on some of them due to publishing restrictions, particularly for Vladimir's, because his very exciting presentation isn't due out in the public domain for a number of weeks, which makes me sad because I would love to see it. But they will be circulated as and when we are able to. So thank you very much, everybody. Enjoy your day and hopefully see you again soon. Goodbye.
Bye-bye. Thank you.